Welcome, everyone. Um, we are ready to get started for our first poster session. Good afternoon, and of course, welcome to this year's 2021 Matrix and GP Track Summit, featuring the title of Disruptive Technologies and Innovations. During this poster session, we will have three posters presenting outlining projects in telehealth. That will give insight into innovations and present new ideas to consider. Detailed data gathering and research into each of these areas is what makes undertaking telehealth research beneficial to all of us. We are grateful our presenters are willing to share their findings and know that you will come away with a better understanding of telehealth. Each presenter will be given up to 10 minutes to introduce themselves and explain their poster, with the remaining 4 minutes left for questions and comments. If you prefer, you may also reach out to the presenters using the chat feature on your screen to ask your questions, and we will be monitoring that as well. In order to make sure that all of our presenters are allowed time to present, we will be staying firmly on the 14-minute schedule for each. We want to thank all of our poster presenters and our audience, of course, for joining us today. Just a reminder, we encourage you to go and vote for your People's Choice on the poster presentation in the Summit app. So look for the option to place your vote. If you have any further questions or would like to continue any discussion with our presenters, feel free to contact them at the Summit. There's an opportunity to identify the attendees and connect with them in a variety of different manners. To do this, review the attendees list and then message them directly to connect for some networking opportunities. They've got tables to join together to have some conversations if that's an option or an interest, and that is found in the exhibit area. So with that, I will turn it to Jason Semprini with the University of Iowa. And Jason, I will have you introduce yourself and your program.
Thank you very much. Very happy to be here and presenting. Like I said, like was just said, my name is Jason Semprini with the University of Iowa College of Public Health and the Department of Health Management and Policy. And I'm presenting today research titled Expanding the Capacity of Rural Cancer Care with Tele-oncology. And this study was motivated by the stark disparity in cancer outcomes between rural and non-rural adults. Despite having a much lower incidence in cancer across many different sites within the body, rural adults have much higher mortality rates. And while there's a variety of issues going into that disparity, one is access to high quality cancer treatment. And we sum that up here by just saying that rural Americans are geographically isolated from high quality cancer services. And even if there is an NCI designated National Cancer Institute designated comprehensive cancer center, there can still be financial and non-financial barriers that inhibit an individual from attending such services. But with the growing interest in telehealth, we have become more familiar with a concept that's not just provider to patient, but provider to provider telehealth models that not just work to train providers in these rural areas, maybe at rural health clinics or critical access hospitals, but also using this type of model to build the capacity and build up relationships to ensure that rural adults are receiving the best possible cancer treatment, regardless of where they live. So we were excited by this promising model that expands the capacity of these primary care and hospital providers through this provider to provider model. But as we're all aware, to implement such innovative telehealth models, financial considerations must be taken into account. So the purpose of this policy review was to investigate what states were allowing payers, insurance companies, whether it's private or Medicaid, to reimburse providers for such provider to provider telehealth training. And we were hoping to do this to motivate further diffusion of these reimbursement policies, to expand the scope of such innovative telehealth into the realm of tele-oncology. So what we did for this study is we reviewed federal and state statutes to find rules or regulations that were governing and, like I said, allowing these provider to provider models, to pay for the time that these physicians were spending working with a provider at a larger institution or even a comprehensive cancer center. And so a few findings, and I will just leave this map right here. So what we see in green, most states have no activity as far as what their Medicaid program allows providers to bill for when working with other providers at a different site through a telehealth mode, whether it be audio or video. So there's a lot of opportunity for diffusion. 3 states kind of are more what a lot of people might think of as some of the more innovative states in the telehealth field, or at least in the reimbursement area, are Washington, Colorado, and New Mexico, have authorized their Medicaid providers to engage with distant providers to be reimbursed for these services, including tele-oncology work. Also very encouraging, though, during our policy scan, we found a handful of states, 6 to be exact, Hawaii, Kansas, Missouri, Montana, Nevada, and Utah, that had developed working groups and task forces to investigate the development and how to best adapt some of these authorized models in neighboring states, and how to implement a provider-to-provider tele-oncology program in their state that would meet the specific rural needs of their residents. Because as we all know, rural in Hawaii is much different than rural in Alaska, which is different than rural in Virginia. So it's important to have these policies modified and adapted, and I think that's what we were most interested in. And what we saw was that these Medicaid programs, which authorized telehealth provider to provider capacity, the only real activity was at the state level. We haven't seen a lot of federal policies that were authorizing such activity, and not any, at least at the time of this study pre-COVID, a lot of attention in the private realm. So we see here, despite little proliferation across the state, and most of it being concentrated in the West, there's great opportunity to build off of these delivery models, not only to expand the reach of high quality cancer care in these rural areas, but also opportunity to build off some of these existing models and have states continue to adapt and modify, and so then we can begin to better evaluate these types of novel provider to provider capacity building telehealth models, and then begin to implement some best practices across the country. And one note I will say, so while I spend most of my time here talking about the state Medicaid policies, there was something called Project Echo at the federal level, and that policy was adopted. It had bipartisan support in, I believe, 2017, and that policy allowed Congress to fund demonstration projects to evaluate these provider-to-provider telehealth, including tele-oncology models. And given the popularity of that legislation, more attention was given to towards funding this at a more high level, federal level. But unfortunately, there was not a lot of progress on that bipartisan legislation, mostly because I think the arrival of COVID. But just to conclude, again, we see some states beginning to adapt their Medicaid program to allow for this novel provider to provider capacity building model. And I think this model here, given the commitment by state payers, can be a fine complement to other telehealth mode of delivery. And with that, I would like to take questions.
Jason, thank you very much.
Definitely.
I enjoyed your presentation there. Any questions from the group? I know that the chat is open as well, and I'm happy to ask questions posed there as well. One question from that I have is, when looking at the Medicaid information from the various states, was there maybe some unstated? I know one of the things when we think about some of the Medicaid programs, a lot of certainly in South Dakota, some of the activities that are allowed are not necessarily called out specifically, in the regulations, and it's more of a administrative component, and so they may not be defined in regulation per se. Is that maybe something that some states that you identified in some of the other states?
That's a great question. I think because of the nature of and again, this was pre-COVID, so telehealth varied across the country, and it varied across service lines. Telepharmacy had different rules than teledentistry, different than primary care, etc. And I think also because this was not direct patient care, there was very little evidence that we could find that there was some implicit authorization that states could in fact submit Medicaid claims to their state Medicaid agency if it wasn't explicitly banned. I don't think that is something that's happening because again, it's telehealth, and there's no patient activity happening in this model. I guess it could happen. It could be provider to provider with a patient in the engagement, but it's not necessary for this model.
Understood.
Mm-hmm.
I do have a question that's come through the chat.
Sure.
Do you have any data on states that reimburse with the usage and what that usage has been over time?
Yeah, that would be great data to have, and I think that's something that will come about because most of these are Medicaid demonstrations. So I guess I didn't say this at first, but all of these Medicaid programs have authorized this provider to provider telehealth capacity building model through a Medicaid waiver. And the intent of these Medicaid waivers is not just to adapt your Medicaid program to fit the needs of your residents, but it's also to allow the Centers for Medicare and Medicaid Services to conduct a more thorough evaluation of your modification. So while that data is not present because these are pretty new models, it's definitely on the horizon. It's something we're going to be considering as we move forward. So expect that to happen. It's inherent in these waivers that they be monitored for their efficacy.
Wonderful, thank you. Any other questions for Jason? Pause long enough for it to be uncomfortable. And I'm not seeing any more in the chat. So Jason, thank you very much. Appreciate
Thank you for the opportunity.
Yeah,
thank you.
Appreciate your sharing your information, and look forward to probably having some people connect with you through the conference app. So watch for that as well. I'm now happy to turn to our next presenters, Dr. Rohn and Christy Seidel. I will turn to you and I'll let you do your intros.
Okay, thanks, Mary. So I am Dr. Kelly Rohn, and I am the Medical Director of Outreach and Innovation at Avera eCare, and also a founding board member of the American Board of Telehealth. And I'll let Christy go ahead and introduce herself.
And I'm Christy Seidel. I'm the Director of Partnerships for the American Board of Telehealth, and I'm also a founding board member of the American Board of Telehealth. So I will pull up our presentation here. Maybe. Where did it go? It's only when you're in front of people that it doesn't want to show your screen. There we be. Okay. We'll go ahead and get started. Everybody can see this. And if you can't, please stop me and let me know you can't see it. So today we're going to talk about how we are working on improving the telehealth education curriculum using a Delphi. So there has been a recognition for over 100 years that by standardizing medical education, the overall quality of medical care can be improved. Over the past 20 years, competency-based education has truly become the norm. To date, telemedicine has not had a standardized curriculum for learners. The COVID-19 pandemic has caused a revolution in telemedicine, as you're all aware of, further necessitating development of quality education in the delivery of telemedicine. In order to promote best practice, we used a Delphi method to develop a consensus on curriculum competencies in telemedicine. So for a partnership, in order to promote the best practice, we partnered with the Harvard Medical Faculty Physician Group to bring together nationally known telehealth experts to create an expert-driven consensus list of telehealth competencies using a modified Delphi method. Regarding the modified Delphi, the Delphi approach is a way of obtaining a reliable consensus of opinions by a group of experts. The panel included representatives from educational institutions, industry frontline leaders, frontline practitioners, legal experts, and administrators from large telemedicine organizations. Due to the multidisciplinary and cross-discipline nature of telemedicine, it is critical for a curriculum to really reflect the variety of perspectives required for a practitioner to effectively navigate this field. The initial 12-hour in-person gathering was held in Boston in January of 2020. Experts from different aspects of the telemedicine field gathered to analyze a methodical review of literature that was performed by the Harvard Medical Faculty Group, who then created an initial set of competencies, which we analyzed and edited by the focus group of experts, and you can see those names on the screen. After the in-person meeting, the competencies were distributed as a series of 3 rounds of anonymous surveys to a group of 23 experts. Competencies which obtained a score of a 4.0 or greater on a 5-point Likert scale, and at least 2 of the rounds were included in the final recommended competencies. For the results, for the literature review portion, 6,966 individual articles were screened by title and abstract. 200 of them were identified as meeting inclusion criteria with telehealth and were reviewed. 154 of those 200 were found to be relevant to the topic of telemedicine education. 55 items were extracted as proposed elements of a consensus curriculum to be included in that initial focus group that met in January. Based on the focus group recommendation from those 55, we did add 32 more items for a total of 87 curricular items for the initial survey. After 3 rounds of survey, the expert consensus on the curriculum created a list of 34 competencies. The categories which provided the most curricular items were ethics, professionalism, and medical skills. The ethical skills included such items as HIPAA, legal compliance, informed consent, reporting, as well as working with patients and providers over camera. The professional competencies included such items as on-screen professional behavior, establishing a rapport, and dealing with difficult situations. And the medical skills piece included physical assessment and the ability to manage special populations such as pediatrics, family groups, and geriatrics, as well as assisting practitioners on the other side of the camera with assessment and procedures. All other competencies highlighted were determining appropriate level of care, coordination of care across multiple systems, documentation and billing, and technical skills to provide the care and to really troubleshoot those situations in which telemedicine interfaces are not optimized.
We were then able to take those competencies and align them with the ACGME core competencies. The most prevalent competencies aligned with systems-based practice, followed by professionalism and then patient care. And then this was followed by the competencies which aligned with patient-based or practice-based learning, interpersonal and communication skills, and medical knowledge. So the Delphi technique represents a unified and unique methodology which is well established and flexible enough to ensure that the consensus competencies and curriculum developed reflect best practices and ensures appropriate guidance for the practitioner pursuing additional training in this field. This is because it's based on best evidence from the literature and then shaped by expert consensus. These competencies provided an educational pathway for healthcare professionals, both new and established in the United States and globally, seeking core fundamentals in the use of telehealth services and provide a benchmark for institutions that want to provide such education. So our goal is to weave telehealth into the fabric of healthcare delivery across the country as a vital tool in promoting access to quality care. Since this study was concluded, we have used these competencies to create a certificate called the Core Concepts in Telehealth. And this course provides a comprehensive curriculum to enable the learner to develop knowledge of telehealth concepts for successful implementation and delivery across a broad spectrum of service areas. So it's online and self-paced certificate course is offered by the American Board of Telehealth. And the course includes modules based on the competencies found in this study. And they include introduction to telehealth, technology, telepresence skills, licensing, credentialing and privileging, legal, regulatory and quality sections, reimbursement, and ethical considerations. So we realized that this may spark some new ideas for research and educational process. Not only how do you create competencies and curriculum, but also how do you succeed in telehealth. Potential topics of research in the future could include further refining curriculum recommendations, and then also studying the outcomes of the educational process of institutions implementing those recommendations. Our hope is to collaborate with like-minded associations and health systems for expertise to continue to grow telehealth training in specific specialties and populations. For example, our first specialty course will launch next month, and it is a telebehavioral health certificate. Again, this will be online and self-paced to engage the behavioral health professional, which has also seen a revolution this year in telehealth. And it's going to be focused on telebehavioral health curriculum that reviews current evidence and best practices from experts in the field through interactive content, video, and integrated case scenarios. So I'd like to thank you for your time and listening today, and we would love to entertain any questions you have about that.
Wonderful, thank you both. Any questions for our presenters? And you are also more than welcome to enter those questions into the Q&A section. question from me. You said that you've got you're launching your first or your sounds like your second module, the first one, but your first one focused on specialty. How many are you anticipating? How many modules are you anticipating?
So for the,
Go ahead, Christy.
sorry, Kelly. Mary, you mean the telebehavioral health course, right?
How many courses, I guess, are you anticipating down the road? So you got your telebehavioral health. Sounds like you had your kind of your intro one already ready to go. So do you anticipate having more down the road?
Yes. So our current course map out for the next 3 years, roughly, that we've developed, I think we have 71 topic areas, specialty areas.
Great, great. And I know I've got a question here in the chat. A question about cost. What are the costs of the modules, and are they only available to physicians? Is the focused attendee only physicians, or is it cross professionals?
That's a really good question. So the intro course is $395, and we offer student-based pricing as well at a lower price, as well as group pricing. So always open to that. These are really for across the spectrum of care. So this can be for nursing, for APPs, for physicians, administrators, people in IT that are doing this work as well, and people who are looking at the legal aspects. So that core course is kind of the beginner course. And then depending on the length of the future courses, they will be priced accordingly, but if they are a similar length, they'll be similar. I believe behavioral health will be that similar pricing. And again, with behavioral health, we really benefit from this kind of course. So including psychologists, social workers, etc., in that particular course. So trying to make sure that we're hitting all aspects of each specialty.
Great. Another question is around, are the modules available to outside registrants or only internal students?
So they're available to anyone. If you go to the American Board of Telehealth website, you can access those easily.
Great. Any other questions? You are also able to just unmute yourself and ask your question directly if you prefer. Well, Dr. Roan and Christy, thank you for your presentation. Yes, nicely done. And just a reminder that hopefully if people have additional questions, they'll reach out to you through the platform and engage some conversations down the road. So thank you very much. And we'll turn to our third and final poster for the day. Sarah McCumber and Maureen Eidecker, I will turn to you and let you introduce yourself and your program and your poster.
Thanks. I'm Dr. Sarah McCumber. I'm an associate professor at the College of St. Scholastica in our graduate nursing nurse practitioner program. We're in northern Minnesota, 150 miles from the Canadian border. And on Saturday, we had about 2 inches of snow. Maureen?
Thank you, Sarah. Yeah, I am the senior advisor for telehealth for Essentia Health. And I retired about 3 years ago and did some special work, some project work with St. Scholastica and some other projects for Essentia as well. And one of the things that we worked on is this poster presentation that really describes some of the work that we've done. And Essentia Health is a clinical partner to St. Scholastica for all of their healthcare programs and is located in Duluth. I'm a registered nurse and I've been involved in telehealth since 1994. So I'll turn it back to Sarah.
Sure. So I'll give a little bit of background about our poster. So in 2019, Scholastica graduate nursing program received a $2.8 million 4-year HRSA Advanced Nursing Education Workforce Grant. And one of the strong areas that we needed to address was telehealth. And we were very lucky to have our clinical partner, Essentia, and I knew about Maureen. So we built in consultation time from Maureen to have her work with us as we developed our telehealth curriculum. One of the things that, as I met with Maureen and we talked about our work across our 4-year grant, we talked about a lot of times people just want to jump into providing the service. And we backed up and really talked about the need to address all the areas of telehealth, like Dr. Roan and Christy addressed earlier in their project. And recently, Dr. Carolyn Rutledge, who is a guru in nursing telehealth and all telehealth, had developed some competencies or areas of evaluation for nurse practitioners, and nurse practitioner telehealth competencies are really involved in 4 areas: planning, preparing, providing, and performance evaluation. And in preparation of getting our students to the providing part, we decided to do some work looking at telehealth workflow process diagrams. And I like working with Maureen so that our students would think more about the planning and preparing part. Maureen, now it's your opportunity.
Lots of times when we think about telehealth, we actually think about the product, the outcome, the actual patient care. And of course, that's, what we're trying to get to. But with the DNP students and even, registered nursing students altogether, there's planning and preparing work that really has to do with administration, leadership, marketing, and some of the things that need to be done, credentialing, that need to be done beforehand. And in the first diagram there in the middle, we have the telehealth planning discussion guide. Now, the discussion guide really has lots of elements, but these are just a little summary of that. And it provides a guideline for the nurse practitioner leadership to be working with the specialty department and the originating site. And so what is the actual opportunity or the problem that's being addressed? Has anyone actually taken some time to actually define that? Is it a market issue? Is there competition in the market that telehealth is trying to address? Is it avoiding travel? Is it access for patients? Is it COVID, a public health emergency? Now we know to ask that question too, right? And who will the providers be? Who exactly are the providers? Their names, the detail, because now we're working with actually the planning. So it goes into how will the physicians be reimbursed? Will it be based on their RVUs, or has that been settled? Is that something that needs to be discussed yet? What diagnoses and ages can be referred for the care? And that's very specific because different specialists might have different categories they want to work with. What is the project scope? Exactly which facilities are going to be participating? Have they agreed? Have they heard anything about this? Who's going to do the communication regarding that? And the next is the financial impact. Are there administrative approvals? Have they been obtained? Has there been some discussion about it? Who's going to do those discussions? What about contracts and agreements? What billing codes will be used? What are the projected volumes? So the projected volumes, for instance, will tell the originating site, gee, I probably need more staff on that particular day when we're doing the video conferencing. What will the schedule be so that it's actually detailed out and negotiated right then and there during the discussion? That's one of the things that I've learned over time, is that we certainly don't have a lot of time to discuss these things, but in a formal discussion where you have your key players there, your specialist, your originating site, and your department manager or director, you can get those decisions made and talked about. What is the cost benefit analysis for both sides? And that's important for the nurse practitioner students to be thinking about. What are the finances? Why is this something that might be discouraged when it seems like a really good idea? Okay, so that needs to be talked about. What resources are needed in terms of the providers and the staff? What will the impact be? Will it just be improved access? Will it be decreased travel for the specialist? Will it be more time available for the specialist to do intake visits? Or will it provide, is there enough specialist care to do follow-up visits as well, or will they only be doing the initials? So all that needs to be talked about. Then the second part is the workflow process map that moves after you have that discussion. You have a lot better idea what will go on the workflow process map. And that the workflow process map is shown there in the second diagram, and that is an actual workflow process map that we developed, Essentia and the College of St. Scholastica together for congestive heart failure for an ambulatory clinic. And there it shows probably a breakdown of about 22 steps that shows the actual visit itself. And it's broken down by the function, referral, who will do it, who will take that, who are you going to accept, the scheduling and registration piece, so that everybody involved knows their step that they're supposed to do. And as Sarah mentioned in the very beginning, the planning part is very, very important, because to become and be ready for the and you feel a lot more confident in the handling of the equipment and the actual care of the patient. Sarah, I'll hand it back to you.
I had muted myself, sorry. So in terms of recommendations, some of the things that if this was to be replicated, we would recommend contracting with an expert telehealth clinical consultant. That was helpful. We also had some key dedicated faculty time in the DNP program, and also partnership with our simulation faculty. Also emphasizing the planning and preparing competencies beyond the providing, orienting the students to the workflow process diagrams. They need to understand the business side of healthcare. And also integrating steps. We integrated steps across several courses, starting with a rural health course, going into our geriatrics, quality course, and a mental health course. And then we are working also on faculty education and inclusion of undergraduate faculty at the interprofessional education practice. And lastly, we would like to acknowledge the HRSA funding that we received for this grant, for this project. Thank you.
All right. Well, great. Thank you for that presentation. Any questions for Dr. McCumber or for Ms. Eidecker? You can either unmute yourself and ask your question, or you are more than welcome to enter it into the chat. Got one. What was your largest barrier to implementation?
Sarah, I think you and I might have to tag team on this one. You know, I think because it is a big project, and last year, much of the work that we did on this was pre-COVID, just getting the faculty to, you know, embrace the material and start to learn it and learn about telemedicine for themselves. I think in order to address that, Sarah is a super user, and that helped a lot. But Sarah, other barrier things that you
I think another barrier for in the academic side is just the time, because this has taken more time than any of us get paid for. So and it is trying to get faculty to adopt new innovation, which is real challenging. So yeah, that's been the biggest.
Yeah, those are big challenges. Do you anticipate now that with, as you mentioned, a lot of this work was initiated pre-COVID. Do you anticipate that the interest and the willingness to kind of jump into it has kind of shifted a little bit now as a result of all of our experiences?
No.
No.
Faculty have had to, sort of redeploy how they're providing their curriculum over the last year. A lot of it is just one-on-one interaction with faculty. So I spent a lot of time as the sort of the super user, the person who wants, I'm going into courses and helping people think about how we can use this. And one of the exciting things is now we're going to go into remote patient monitoring. So we're going to talk about how we can implement that in our curriculum across the undergraduate and the graduate curriculum. So, and we have work groups, but a lot of it is just one-on-one sales. I feel like I'm a salesman sometimes.
So that's and a good one, Sarah, who uses it in her own practice in neurology too.
Yeah.
So that's a pretty strong statement. The other thing too is that there is more awareness, with COVID. So there's more awareness. People know, well, this is something that I need to learn, and need to become proficient with. And also it's a plus for a 4-year grant, so that, and we are just in year 2 now of the grant, where we're working with remote patient monitoring this year and getting that started so that the students will have availability to the actual systems to use, along with the devices and pairing up for data. This is a congestive heart failure workflow process map to the clinic, but we also have workflow process maps developed for different sites as well as to the home.
Mm-hmm.
Great thought. Okay, yeah, good point. Thank you for the clarification. All right, any other questions for our presenters? All right. Well, thank you all. We appreciate all the presenters who were willing to come and share their posters today. Thank you tremendously. It is your involvement that helps to make this conference a success, and your willingness to kind of help us all stretch our thoughts on what's going on in the world of telehealth, and not only today, but into the future. So thank you all. Remember that all of you are able to interconnect and continue your conversations past this point. Also, a reminder to please place your vote for your favorite poster presentation. This is the first of, let's see, looks like 7 different sessions. So please take the time to listen in to the other posters as well. There's a lot of great information there, as in addition to all of the breakout sessions. So last opportunity for some comments.
I'd like to say that Dr. Carolyn Rutledge, who prepared the 4 Ps for nurse practitioner telehealth, is one of the attendees at this conference. So I hope I presented your work a little bit correctly, Carolyn.
Wonderful.
Thank you, Mary.
To connect. So thank you all, and we'll look forward to seeing you later on throughout the conference.